That's a great way to start off the day. And we're off. So the one complicated thing to this whole situation that I found the most difficult was that I was starting off working with a brand new EMR, electrical medical records. And what this means is that I had to get used to a system, not necessarily that I had to learn anything that was medical or any knowledge that I needed to practice on and make better, but just get used to how their system worked and how they like to do things over there. So after I got done with that, after about the second day, on the third day I was able to do it, which was yesterday, much more efficiently. And on the fourth day, which is my call day, I think I had enough preparation to be a little bit more confident. You know, I've been working at a facility for about for less than a week, but the people there seem pretty nice. It's over in Hialeah, which is a high density of Cuban people, Cuban patients, very much Spanish speaking population. And in my personal opinion, I love to be able to take care of the patients thoroughly, so I did take it upon myself to learn Spanish and speak it fluently. My fiance is Cuban, so that did help out a bit as well. And now I have a lot of confidence speaking to patients in Spanish. Never overstep or get overconfident or not know when to ask for help. But the fact that I'm able to converse with my patients and be there to address their needs in real time helps out a lot. And you'd be surprised about your capacity and your ability to learn new skills and actually mold your brain into doing exactly what you want. It's a very powerful tool. Yeah, learning a whole language, sounds like a very cumbersome task. But when you do it and you're able to really have that genuine patient care, and there's not things being lost in translation, it really does help out with the overall care of the patient by a whole lot. You're not just popping in and saying yes, and then popping right back out. I feel like everybody goes into medicine for patient care, so why wouldn't you want to do all that you can to actually take care of your patients that you have the privilege of taking care of? I'm hoping that I get a lot of downtime. I'm hoping that it's a quiet night so that I can study, so I can write up case reports and that I can present later and just put myself in better positions. As you can see right now, I'm not bumping into a whole lot of traffic. I'm kind of just cruising straight down the highway. This isn't a normal thing at all. Usually there's traffic that stands still and will keep you here for hours. If anything, this commute that I'm taking actually doubles when it's about 3 p.m. and everybody's awake. So, I do enjoy leaving early because it's not traffic. I get to get everything done before the attending arrives. Everything is just copacetic. And that's how I like to approach it. There's some shady thing going on. Try to get by and get to work. What a life. There's a couple of videos that I've been interested in making as well. A lot of people ask how you do medicine or how you become a doctor with tattoos, because I have a tattoo going all the way down my arm. I have a full arm sleeve, and they're like, are you able to become a doctor with that and things like that? Are you facing discriminations and biases? And there are also people who wonder how much I actually make, if I'm actually making money that's actually, worth 12 years of education and, nonstop research and studying. So I think I'm going to make videos on those two things, really just sharing what it's actually like to be in this position and have all that going for yourself. I also have really pretty long hair for a male because I have dreads, so these are questions that I actually get a lot, and I think it is important to share with people how I manage it and how I deal with it. I gotta give it to Miami. The scenery you just can't beat. Driving through here, seeing all the big buildings, the water, palm trees, it's a breathtaking view every time, and I've been living here my whole life. I actually stayed in Miami up to the age of 17. Then I graduated high school, zoomed off to college over in Tallahassee at Florida State University. And I've been here, when did I get back here? I got here back when I was about maybe 24, 25. After medical school. Came back because I wanted to help out my people, my community. And the people in my community suffer from a lot of things that my specialty caters to and treats and helps bring people out of. And that's strokes, and there's a lot of rehab and getting people back their function. It's such a meaningful work to do. It's so helpful. It's such immediate gratification. Still about 9 minutes away. Wish you guys could see these beautiful sights instead of having the camera face me. But I mean, what do I usually see at an acute rehab facility? We got patients who are post-op, so they'll be coming back for whatever really severe cases that they just went through, where that's, going through certain procedures like thrombectomies, or they just had surgeries, they had an ORIF, or they had, arthroplasties. Orthopedic surgical cases post-op usually, but all surgical cases post-op usually. Patients who went into the ICU had crazy cases. I had a couple crazy cases that I've seen today, or not today, I've seen during my few days working at these facilities. I've had a couple crazy cases that I've seen in just a few days working at this facility. There we go. That really piqued my interest. I'll probably be writing a case report on. But man, we see everything usually. You can see the whole spectrum of medicine here. And a lot of our patients tend to have these psychiatric components to them as well, because they've been dealing with these ailments for so long that it does cause them to suffer from a bit of depression, suffer from a bit of anxiety, and then they need to have that managed as well. So what I do enjoy is that we do have psychiatrists come to the facility as well to make sure that the patients are okay. Because if you're not doing well mentally, then you're not going to be able to push yourself, have the right motivation and approach to fixing yourself physically and, participating in physical therapy and things like that. So I want to make sure that these patients are in the right headspace for them to really participate in physical therapy and get better. And then we also have neurology, who's also there. I'm a big fan of neurology as a specialty in totality, because I feel like we do a lot of the same things. There's a lot of overlap, but they go a lot into the minutia of the pathology that the patients are going through, which provides a really fresh perspective when there's things going on that don't seem very clear, like a metabolic encephalopathy, for example, which is just a big term for this patient is in an altered mental state and we don't know what's really contributing to it, because there could be many factors, from infections, medications, and so forth. So, I mean, there's a lot of specialties that come through the door, and it's really, refreshing to see. What's interesting here is that we are the primary team. Physical Medicine Rehab is the primary team for this rehabilitation facility. And you have people like internal medicine or family medicine be the ones that are consulted to come and see the patient, which is, something that I don't usually see. Usually PM&R in itself is like a consult service. People would consult us and we'll go see a patient, let them know what we think, and then go from there. But in this situation, we are the primary team that takes care of the patient, which is, I think, how it should be, honestly. I feel like in a lot of circumstances, internal medicine is put in a really tight space when there's patients that come in that are maybe primarily ortho, or primary surgery, or primary OBGYN, and then they pass them off to internal medicine just to keep them and watch them, while the other specialties operate and make all these changes that they don't even run by the primary team. And that could be a little nerve-wracking, because you have your patient who's going through this entire care plan that you're not really curating or a part of. However, you're responsible for everything that happens with them. It really is a bit confusing, and I think it's very unfair to do that to internal medicine or family medicine. So for this to be patients that are in need of rehabilitation and need that plan and that structure, for us to be the ones who are the primary team overseeing the patient, I think that makes a lot of sense. And I prefer it that way, because you have a lot more control over what's going on. That's a big thing with me. You'll notice that I do like to be in control of a lot of things. I like to know what's going on. I don't want to be in the dark about anything going on with the patient. But you do know what's going on with your patients. You're the one taking care of your patients, and you're moving in that manner. And that's refreshing to me. And we still consult internal medicine to come in, make sure the patient's okay and hemodynamically stable and things of that nature, and offer their expert opinion, which is very, very nice. And I actually appreciate that, quote unquote. I love that for them because, I think that's the way that it should be. I don't think that as a specialty, you should be primarily responsible for a case that you're not even primarily taking care of. That's my soapbox. Okay. Feel like I've been yapping for a while, but we're headed there now. We're about 4 minutes away. What I'm gonna do is I'm gonna get in there. I'm gonna go to the first floor. I'm gonna go sit down next to the really nice nurses and ladies and the older lady there. And I'm gonna tell her hi, sit down, and then get straight to work. Start looking at my patient. Pick up 3 more patients because overnight we had about 6 new admissions, which is okay. I'm sharing them with my co-resident, so he'll be taking 3 and I'll be taking 3. And after that, we'll go from there. And then I think when he's done, he'll leave, but I'll stay and I'll be there till 10 p.m. Taking any rapid calls, meaning if any patient starts to seem a little bit unstable, I go and assess the situation and monitor whether they need to be transferred out or they need to be stabilized here and kept here. And what else is there? There's also codes that can happen, and I think that's about it. Every admission that comes in during that time, then I see and I, write my notes, admit them, and go from there. So it's gonna be good. I don't know if it's gonna be a lot of downtime. I'm gonna ask my seniors about it, see how it goes for them usually, and see if I'll have time to study and write my case report and make this day really academic. The biggest thing for me is going to the gym, so we'll see if I'll have energy to go to the gym afterwards. Maybe I can show you guys a split, show you guys how I stay. I'm pretty decent shape. I'm not gonna say that I'm the, strongest dude in the world or like I'm, the peak of athleticism. But I do enjoy my physique. I enjoy my physical capabilities. I think that's a lot of people as they get into this medical profession or they get into this aspiration or this career choice, they start to let themselves go. They're not taking care of themselves as much, and it's not okay. It's really bad. So we'll go ahead and we'll take the time to review all of that if I have energy and time to go to the gym. The thing is that Fabletics sent over these new scrubs. These scrubs are fire. These scrubs are amazing. As always, they do such a good job over there. And they also sent me workout equipment so that I can show you guys, and it's gonna be amazing. I got this great gear to go train in the gym. Super water resistant, sweat resistant, and just optimal for performing. And I think a brand that prioritizes health, being a healthcare worker, and keeping you in the best shape as possible and keeping you really healthy is like a brand that you got to stand behind. Like I'm really loving the partnership that I have with Fabletics because it really stands for everything that I believe in. And the crux, I think, of my specialty completely, physical medicine and rehab. James has the entire lunch and breakfast schedule memorized already. I don't. I need to put that into memory so I can see when I can go eat something and get right. Yeah, because I'm gonna have to eat. There's no way I can fast today. There's no way. Alright, let's get the rounding process started. Try on all my patients and go from there. The beginning part of a call shift is just gonna be you pulling up and doing your regular shift, which bada bing bada boom. If you've been doing it a long time already, you got it under control and you'll just get out of there. The next part is gonna be staying behind and taking care of whatever else comes. So right now, if anybody in the hospital, knock on wood, anybody becomes unstable, have to go and have to address that situation, and my biggest role is going to be doing everything I can to prevent them from de-escalating and having to go to the hospital and be readmitted, because that would mean that they would have to go through this whole process over again, and more than likely would have to come back to rehabilitation. And it would be on us, because then would we be, capable of keeping the patient stable after they've been stabilized in the hospital? So it's a big thing to make sure that people who get discharged from here don't end up going back to the hospital. So that's one thing. If somebody codes and somebody's dying, then I have to go and have to run that code. If you're wondering where I'm at right now, this is our little call room, our little resident room for residents. Like, it's literally not that big. I barely touch one wall to the other, so it's just a little room. All we have is a computer to do our notes, and that's about it. I can give you guys a quick tour. It's gonna be really, really quick. That's the door I came in. That's the wall behind me. This is where my backpack's at. You don't want to put your backpack on the floor in a hospital. That's the computer we use. That's my laptop over there. I like using 2 computers, 2 monitors. That's my cell phone charging. And yeah, that's pretty much. I'm a PGY2, meaning I'm a second-year resident, so I'm more senior than somebody who's just starting out in residency. But the thing is that I specialize. So I did, my first year was essentially just internal medicine. Not my specialty at all, but just internal medicine, because I truly believe, and I agree with them doing a process like that. Every doctor should have a year of internal medicine, because you learn how to take care of the whole patient without understanding how different parts interact. Then you'll never really be able to master your own niche, and you'll never really understand why things are acting abnormal, because you'll only be able to think in that one spectrum, and that's not good. So my first year was just internal medicine, and this year is PM&R. So this is like kind of like my first year, even though I'm a second year resident. And this is my first, like 3 days ago was my first day using Epic, and now I'm taking care of a whole hospital using this EMR, and we're just here doing what we do. But it's good. The nurses are always some of the smartest people in the hospital. They know exactly where to go. They know what to do. They know how to look for it and what they need to get done. They're the ones who spend the most time with the patients. They're not like doctors hiding out, sitting in a closet. I can't hear you. What'd you say?
I said I feel so special.
For what?
Because I'm getting a call from you.
Oh. I got done with one of my patients, and it's time to chill out and then wait for the next whatever that could be. Could be at any time. How was your day?
It was uneventful.
That's good.
Yes.
That's a good thing.
Huh?
That's what you want in medicine. You had class? What happened?
I had class in the morning for an hour, and then I got out, and that was my only class today.
No, that's smooth, bro. Nice. You got a lot of studying done, I bet. Well, I have a question.
Oh God.
If you have someone who's passing, like, yeah, say like a parent is passing, and they're like at the end of their ropes, and they get they get they get an infection, and you can remove a piece of the lung to try to get rid of the infection and then try to save them, or you can put them in hospice and comfort care. They're bedbound, they can't move, they can't do anything. They're like ANO times 0. Well, what would you pick?
What did the parent want?
This isn't my patient. I'm giving you like a random scenario based off of like what I went through.
I know, but in this random scenario, did the patient ever voice what they wanted?
That's true. They never did. Not clearly, at least.
And you gotta do everything you can to save them. No hospice.
No hospice? Oh, bro, just because they didn't tell you, they wouldn't want to live like that?
Well, hospice isn't life-saving. It's life-ending. Like when you hear about somebody who goes into hospice and then they like come out alive.
That's true.
You can't send them to die, bro.
So you just send them to hospice?
They didn't. No, you can't. That's sending them to die. You can't do that. They didn't say that they wanted that.
But it's comfortable.
Okay, well, according to step 1, you're not allowed to die. You have to do whatever the patient wants. And if the patient doesn't voice anything and they don't have a proxy, you have to give all life-saving efforts.
It's not a patient, though. It's your parent.
I would still do the same thing if it was my parent. And as a matter of fact, if it was my parent, I would do it more. Because what the f***? Oh, you want to talk about it? Oh, Have you taken a nap?
No.
Oh.
I go straight, bro. Straight through everything.
No, I was just gonna feel betrayed if you laid down to take a nap and I didn't get a phone
I
call.
don't have
But
rooms here. It's not like the intern here.
glorious.
This closet is literally all I got.
I love that little closet for you. It's your closet, baby.
This is my little closet. I'm the king of this little area.
You're the king of a lot more than that little area, sweetheart.
Oh, great.
Should have known better. The second I got close to being done, somebody wanted to get agitated for some reason, start throwing punches at nurses. Which I never knew that nursing could be such a dangerous job, but oh my gosh. They're the first ones in the line of fire all the time. Oh. We're good though. We're 16 hours. What was that? 16, 17, 18, I don't know, some number. We're a number of hours out. You know, I didn't die. Nobody died. It's all good. Yeah, it's all good. So we just go from here. I think it's honestly just vibes now. It's all just vibes now. And that's it. We're 16 hours out. We did it. We did it, you know? You know? You know? You know? Honestly, shout out to my seniors for sprinkling in those tidbits, that tea. Wow, I had that on my neck all day and never moved. What the heck? That's insane. It's like a dent there. And another one bites, and another one bites, and another one bites, and